can still hear Han. Very good morning to you. Thank you for joining us for our first event of 2022, NHS Backlog, delivered to you, our valued audience, by National Health Executive. A huge welcome to new faces joining for the first time, and hello to those of you who have returned from last. Today's NHS Backlog event will be packed with opportunities to network and acquire more current sector knowledge. So I hope you're looking forward to what we've got in store. Whilst the National Health Executive team is always keen to deliver content which inspires innovation on the platform long after the event has finished, we must thank the industry leaders and experts who've taken time out to join us today to share their high-quality insights. Due to the standard of content that will be shared on our NHE365 platform, it's worth me pointing out that all content is CPD certified. For every hour of content you watch live, you'll earn 1 CPD point. To receive your certificate, please email the NHE team at marketing@cognitivepublishing.com. That's marketing@cognitivepublishing.com, and they'll sort it out. We also provide the opportunity to give back through some friendly competition. Whilst learning today, our gamification tools will be active. Score points by engaging with the platform's different elements. Join a live session, there's 50 points earned. Make a connection with another delegate on the platform, 100 points. Ask a question in a session or engage with one of our exhibitors in the digital marketplace, another 50. You get the gist. At the end of the event, those who finish in first, second, and third places respectively will have £250, £150, and £100 either the Magic Breakfast charity or More Trees in their name and organisation. The Magic Breakfast charity gives a child a nutritious breakfast and a chance to succeed at school for every 34 pence donated. So a £100 donation means that nearly 300 children get a good start to their day. Or if you decide to donate to More Trees, for every £1 donated, you guessed it, a tree is planted, helping our climate. You can only be in with the chance of winning, of course, by engaging with all of the great content we have to share with you and the other delegates here. So there's a bit of background. Let's move to the focus of today. We start by heading back to November 2021, when the Chancellor announced £5.9 billion of the funding to help the UK's health and social care system address the growing backlog. This influx of funding is aimed at providing much needed support to NHS staff and patients. Throughout today's event, we'll examine how healthcare professionals are addressing that backlog without losing sight of their tireless dedication and above and beyond commitment to patients across the UK during the pandemic. COVID-19 transmission placed unprecedented demands on an already stretched NHS. As we navigate the topic of the NHS backlog, we'll investigate how the NHS will continue to rise to the challenges of restoring services, meeting new care demands, and reducing backlogs caused by the pandemic. We also have great networking opportunities throughout the day that can be accessed via the speed networking function. And I encourage you to collaborate with your colleagues as another great source of education. This all plays a part in the community we're growing to extend the reach of knowledge and connections shared today, which can be accessed at any time to work with your busy schedules. Also on the NHE365 platform, access to a wealth of resources on our on-demand content alongside the digital marketplace, providing valuable expertise for you and your teams to digest at your leisure. Finally, feel free to share your thoughts and experiences today across social media using the hashtag NHE365. That's hashtag NHE365. So with the scene set, let's dive into our first panel topic, recruitment and retention. The NHS workforce provides healthcare to more than 55 million people in the UK. However, with rapidly rising demand and continued limited funding for the NHS, further challenges are posed to the NHS, such as how will the workforce grow and how will staff be retained to continue providing services to the UK public? We'll investigate methods of recruitment, including apprenticeships and traineeships. And our panel of experts will help us explore employee engagement, benefit and reward programs and discuss what can be done to boost morale and support good mental health. I like to make these debates a conversation with all of you included in the dialogue. So please do use the Q&A function, which you'll find on the right-hand side of your screen, and I'll pose some audience questions once we get going. So let me introduce you without further ado to James Buchan, Senior Visiting Fellow at the Health Foundation, Timothy Phillips, Director for Health Value for Money at the UK National Audit Office, Anna Telfer, Nursing and Midwifery Practice Education and Workforce Lead at Newcastle upon Tyne Hospital's NHS Foundation Trust, and last but certainly not least, Shilpi Sahai, Head of Human Resources and Organisational Development for the London Shared Services NHS-EI. So let's get cracking. And we have got a full house. I'm glad to see that we've got Anna with us, because we weren't sure whether Anna would make the beginning of it, but I'm glad you're there, Anna. Tim, if we may, can we start the ball rolling with you? I mean, we've all been reading, haven't we, over the last few months, some fairly alarming and concerning headlines. I'm just wondering, what is the scale of the challenge facing the NHS in terms of backlog as we emerge from this pandemic?
Sure. Morning, everyone. And I think it probably is valuable to set the scene, even though much of this will be familiar to all of us because of our working lives and also what we see in the news. I mean, we have an elective care waiting list of just over 6 million now. 311,000 of those people have been waiting on that list for more than a year, and that figure before the pandemic was in the low single figures of the thousands. We also have an NHS that has to maintain readiness for continuing to fight the COVID pandemic and potentially for new spikes. That means infection control measures, divided hospitals, and of course, and I know you were absolutely right, Helen, to talk about the tireless workforce of the NHS, but that tireless workforce is also tired. And so we have a workforce that has been working at emergency rates for almost 24 months, with consequences in terms of sickness absence and stress and vacancies. I'm sure I want to talk to more deeply.
Gosh, you make a very good point there, actually, that the workforce is tired. And when we get to Anna in a minute, that's something as well that perhaps we can explore with Anna, because I know she's got a massive workforce. But Shilpi, I just wondered if you want to add to that kind of description of what exactly the backlog is and what it actually means for us.
Thank you, and a very good morning to all. Backlog, I mean, we've all heard and thought about it, but backlog in secondary care consists of patients who've not accessed the care or interventions that the NHS would normally have delivered, but which was disrupted as COVID-19 impacted service delivery. This includes, but is not limited to, patients on a waiting list for treatment, patients who've not yet presented to their GP to seek a referral, patients who've had referrals and procedures delayed or cancelled, and patients who've had referrals refused because of lack of capacity. The backlog does not necessarily include those that require care but have either not yet presented or have had referrals cancelled. So this helps us, if you like, understand the scale and scope of the problem and how recruitment and retention issues then emerge against the current demands and our ability to deliver. Hope that helps.
Yeah, it certainly does, and we'll explore recruitment and retention in a moment. Just saying good morning to Anna. Anna, your workforce is around 17,000, I gather, in the Newcastle Trust. I'm just wondering, how are things for your teams on the nursing and midwifery front line? And I'm sure you'll probably echo Tim's thoughts about the workforce and being exhausted and shattered, I would imagine.
Absolutely. Yeah, that's right. That it is a sizable workforce. First and foremost, they're absolutely each and every one amazing, but they are tired. And just following on from what Shilpi mentioned there, not only are they worried about their own lives and considering what they've been through over the last 2 years, they are thinking about all of the patients that they've looked after. They're thinking about how patients are going to present, given that they may not have accessed services. They're thinking about how they can provide that service and have continued to do that over the last 2 years. They are tired, but they are still wanting to provide the best service and the best quality that they can. And that is commendable on so many levels.
Absolutely is. James, you work internationally, including for the World Health Organization. How does the UK compare with other countries in terms of how its healthcare workforce has responded over the last 18 months to 2 years?
Good morning, everyone. I think I'd firstly just reinforce what some of the other speakers have already emphasised, that there's been tremendous stepping up by individual workers within health and social care, and that has helped the country and the system tremendously over the last 18 months. But we do need to recognise that we came into the pandemic with about, for example, 100,000 shortages in the NHS, which meant that we were already understaffed, already stretched, and we then faced this existential threat almost. If you look at how the UK compares with other high-income countries, that shortage issue has really been one of the defining characteristics of how we've had to respond. And I think what that has meant is we've placed more emphasis than we should do on individual resilience across the last 18 months. And it will slowly but surely over the next year to 18 months, I think we will see the negative impact of that. Where I would say there is one positive is that because we have a national health service, we've been able to coordinate aspects of the response quite effectively. And I would point particularly to vaccine rollout, that because we had a system in place and we had well-trained staff in place, we brought in volunteers quickly. The early phase of vaccine rollout was clearly a success factor, and that was predicated on a coordinated system and well-trained staff being available.
James, I think you're alluding there perhaps to the increasing concern about NHS staff burnout, and that's something I've witnessed recently in the last couple of weeks with 2 emergency 999 blue light ambulance visits to hospital with my mum, and saw firsthand what was going on there. What are the priorities, do you think, for effective policy response?
I think we have to recognise that we cannot expect staff to continue to bear the brunt of this on an individual level. The evidence of the impact of burnout and health is very compelling. Burnout leads to lower productivity, poorer quality, and probably then increases turnover of staff already in the system. So unless we get at this issue, we're in a very dangerous, vicious cycle. Policy responses have to be coordinated, have to be at organizational level, and mustn't only look at individual resilience and well-being. That's part of what we need to have in place. But if we continue to emphasize the individual response and the individual having to bear the brunt of the challenge, that in itself will create burnout. We've got to look at organizational coordination across issues such as staffing levels, giving staff respite or areas. We've also got to look at some cases, I think, they're recognizing that some staff will be looking at having reduced hours. Rather reduce their hours and keep them than see them go. Just an underlying point here is that the so-called big quit of many staff leaving, we're not seeing that yet. They have stepped up, they've continued to work, but it is inevitable, I think, that we'll see increased turnover over the next year or two.
Yeah, we are so blessed, aren't we, in the UK, that we've got such exceptional people, and you know what they've done over the last 2 years is just above and beyond. Tim, I'm just wondering whether the challenges that are affecting the country are spread evenly across the country, or whether you're seeing, we've talked about levelling up, don't we, in lots of different ways, whether we're seeing an uneven spread. But also, what do you mean as well when you talk about missing patients in recent reports? Are they patients who haven't presented, therefore perhaps our backlogs are longer than we even realise, if you see what I mean?
Yeah, I'll deal with that one first. Shilpi, I think, already did a good job of explaining what a missing patient can be. One of the things that perhaps useful to address is when you see numbers of missing patients, there's often a really wide range. So in our report, it was 7.6 million to 9.1 million missing patients up to last September, even bigger now. Actually, the reason for that range, it's worth explaining, is usually the lower number assumes that 2020 and 2021 would have been like 2019. And so you just run them on and add up all the people who didn't turn up. Actually, as lots of you will know, the NHS has like that. Demand for healthcare has grown every single year. And the higher number then is what happens if you factor in that growth that would have happened had the pandemic occurred. So you can argue about how many of the missing patients will return. Some will have got better. Some won't be with us any longer. Some will have found other ways of dealing with their problem. But in terms of what's more likely to have happened in that range, the higher number of who was actually missed is probably closer to being accurate. It factors in long-term growth in health demand. In terms of, is the issue spread evenly? No, it isn't. It's interesting listening to James. By their nature, things like goodwill and professional ethics, on which people are running at the moment, a bit like a car running on fumes, they don't run out evenly all at once everywhere. But that doesn't mean that they last endlessly. So that's one issue which I think means problems are not evenly spread, and some trusts, some parts of the health service are more compromised than others. Perhaps useful kind of to illustrate this, if you look at the top and the bottom in terms of the STP areas in the NHS last September, because that's when we did the analysis. So Southwest London has the lowest number of people waiting for longer than on the elective care waiting list. And that's 21%, whereas in Birmingham and Solihull it's 51%. So that's a huge variation in terms of how long patients are waiting for elective care. And of course, a huge variation in the stress and intensity of work that staff are facing in those areas.
Shilpi, I know you have a lot to say on recruitment and retention. Within the context of people, plan and promise and the development of integrated care systems, where does recruitment and retention sit as we move to recovery, and what kind of recruitment practices might help to reduce and to manage the backlog?
That's a very interesting link, and alluding to everybody, everything that the previous speakers have said. Within the context of people plan, I mean, it'd be helpful just to briefly give you a glimpse of what the plan is all about. So it focuses on looking after people, belonging in the NHS, and new ways of working, and of course growing for the future. And all these strands were tested during the pandemic. And as ICSs progress to become statutory bodies in July, they are tasked in the main to develop provider collaboratives for delivery of improved care for patients. So for example, some acute trusts managed their high volume, low complexity day cases and short stay surgery by relocating them to other hospital sites and ICS partner trusts. And this then links to the plans to restart and restore elective activity, addressing both the surgical backlog and new infection prevention and control requirements. And so these are not just the logistical or structural exercises, but key factors then in implementing these plans are, for example, revisiting some of the roles that our staff engage in. So, for example, you need to revisit the accuracy of the current job descriptions that they have, or indeed the banding and the development opportunities that are in place for them. And in response to these emerging needs, staff engagement events go a long way with the view of introducing new roles. So, for example, future registered nursing associate roles within the surgical context. And alluding to the previous speakers who've talked about engagement and developing critical skills, COVID has indeed negatively impacted critical areas of skills development, redeployment opportunities, and new models of care. Particularly where the greatest activity pressures have been felt, so for example, ICU and the emergency departments. Coming to recruitment, high vacancy rate means existing staff are under more pressure to meet rising patient demands and are often overworked and exhausted as a consequence of COVID and the current acute pressures. It is therefore important that our recruitment practices are modernized to support rapid deployment of talent and indeed new ways of working. So what recruitment practices are we talking about? I mean, there are many, but I think some of them are wellbeing offers. What do they include? And currently, again, speaking from experience, some of the barriers to include lack of protected time and physical space really to access these offers. There was a lot of talk about sickness policy changes as they impacted staff, and Department of Health and Social Care developed terms and conditions related to COVID-related sickness to support staff with full pay, whilst they were considered infectious, so they did not really transmit the infection to patients. And these intentions were not really, these policy intentions were not really intended to be used for long-term sickness related to COVID. And therefore, this issue then needs to be resolved. And this is something that then links to, if you like, turnover as a consequence of exhaustion. So detailed action plan, again, for retention of staff may include a number of initiatives, for example, supporting new starters, staff who are in mid-career, who may have mid-career needs, and supporting over 50s and those who are intending to leave the trust. At a very, very basic and local level, adopting use of self-rostering that reduces time spent by managers in finalizing the rosters and potentially reduces sickness absence as well. And then, there was a talk about internal transfer policy mechanism that has been introduced that encourages staff, if you like, to move to other roles within the hospital rather than having to leave the trust. And again, changes to the leavers process to ensure there is increase in completion rates of the exit survey that would then give you the rich information to improve retention. So, and again, the retire and retention initiative, simply because of the workforce available to us is very limited. And so therefore, making one-to-one contact with every single member of staff registered for the pre-retirement course to discuss the options of retiring and returning to work, and really highlighting value of the reward systems that exist for staff here, and creating a balance between job training and theoretical training, if you like, before redeployment, as COVID has shown us, there can be efficiencies that can be gained through hands-on experience as opposed to classroom or online training. So really, these are some of the bits that come to mind that I, thought that I'll use by way of examples, if that helps.
Wow, Shilpi, that was a very full and frank answer there. I noticed Anna was making a few notes. So Anna, do you want to follow on from that? And from your perspective as well, it's so important, isn't it, that you've got a workforce with the right skills, and that also that your team's well-being is looked after as well with all of it. But I'm sure there were points that Shilpi made there that you can add to.
They're absolutely right. And ironically, I think the first point that I wanted to raise is in terms of workforce plan, it's about having that consistent and cohesive understanding of what that entails, so that a nurse, a Band 5 registrant, for example, has the same expectation as a director of HR workforce. And Shilpi absolutely, brought that to the fore. I think some of the things that are really, really important is starting at the top and thinking about that organisational culture, because if we're going to absolutely support our staff with their, to recognise and realise their health and well-being at an individual level, sometimes it's just being able to say, how are you? And have that really authentic discussion with somebody and have the time to do that. So that leads us to think about how we can be truly visible and there for staff. But obviously that's a cultural change in some organisations. It's making sure that is at every level of an organisation. In terms of the skills that we need, as much as we've had some, obviously, there's been some negative impact from the pandemic, absolutely. But it's also been an opportunity to really try and test some ways of working as well. If we think about ICU capacity, what it's really provided us with the opportunity to look across the workforce to see how we can upskill people to be able to support colleagues in ICU and actually provide them with different developmental opportunities as well. And certainly from, anecdotally, that's been an opportunity for some who thought, actually, I like this, I can see myself doing this. So it's being able to harness that and really take that forward. Again, I think it's just making sure that everybody's benchmark is absolutely the same. So if we have an understanding, as Shilpi mentioned, in terms of making sure that a job description is what it should be, it's about making sure that the competency framework that we have around that particular role is absolutely clear to everybody. And then how we get that person through those developmental opportunities or what they might need to make sure they have that competence is really, really clear as well. And that's a piece of work that I think every organisation will be at varying stages of, but it's so important for that individual, for that team, for that directorate, and obviously for that organisation, so that actually we can say that not only in terms of pipeline into nursing, for example, within nursing we have got those clear developmental opportunities, but that clear competency framework for what we require of everybody. Obviously, with recovery, that skills matrix, that competency framework is going to look slightly different, because we're going to need slightly different skills at pace to be able to manage that. But if we are all sighted on that, I think that's one of the most important things. I think the other thing is just being very, very clear about pipeline and being able to articulate what that journey can look like. Because the other positive that we've learned from COVID is, in terms of the general public, there's not just a lot of sympathy for the NHS, but there's a lot of people who've seen this as an opportunity to really give to the NHS and to be part of that. And I think we need to harness that, and we need to nurture and support that as well. So attracting new to care is such a huge thing, and making sure that they've got realistic expectations of what a role could be, but making sure that we can clearly articulate what that pipeline and what that development through an organisation and career progression can look like. We see that through, from the trainee nursing associate, registered nursing associate, you mentioned earlier apprenticeships, all of the things that can support us to get there, and obviously through registered nurse degree apprenticeships, we can then be able to provide that career progression to members of the public who absolutely want to be with us. But with that, in terms of the skills, it's about fully understanding through training needs analysis what it is that we need for each individual service and being agreed on that. And I think staff ownership is really, really important, because they are doing the job. They will tell us what it is that they need to do that job, and we need to listen. We need to be able to add that into that plan to make sure that they have those opportunities, and that they feel that they've got the permission to be able to go ahead and do that. We've also got, obviously we are in the second year of it, but in terms of continuing professional development, the Chief Nursing Officer has provided us with that opportunity to be able to provide every nurse, midwife and allied health professional with their £1,000 of CPD. What we need to do is be able to make sure that that offer is absolutely advertised, communicated to the workforce, so that they know that they can take that. Because again, if they feel that they're able to develop, that's going to support them to provide the role and quality in what they do, and to provide the role to the best of their abilities as well.
Gosh, Anna, you've done the same as Shilpi there, provided there's a lot of great content. James, I guess it's trying to, what do organisations prioritise? Everything Anna said there was so important. There's got to be some focus, hasn't there? And what would you suggest need to prioritise?
At the risk of saying everything, and not getting very far.
I thought you might say that.
As an entry point, I think it has got to be, what can we do to improve? And what can we do to keep the skilled, experienced staff we have for longer, so they can continue to contribute? And in a sense, that provides some ability to buy time to allow these new initiatives that are being described to begin to come through in terms of delivering more staff. So the focus on retention, I think, is going to be critical over the next couple of years. And a starting point for that, I think, a very simple metric: every time a nurse leaves the organisation, the cost of the organisation is equivalent to at least several months of salary. For an experienced nurse, it's probably equivalent to 2 years of salary. So the lost skills, if you turn it into a monetary crude estimate, gives you some sense of where the focus should be in terms of allocation of resources. So the points I made earlier about respite, rotation, reduced hours need to be considered. We mustn't lose sight of pay in all this either. And often the whole process of pay, because it's done nationally, is kind of marginalized to a degree at the organization, the level. But a point from last year, England was the only one of the 4 UK countries and many other OECD countries who provided some sort of one-off COVID bonus to their staff. England stands out as not having done that. I think that was a missed opportunity to reinforce a positive psychological contract between the NHS and its workers. So that's last year. This year, we're looking at a situation where the peer review bodies will be looking at the usual indicators: recruitment, retention, shortages, morale, motivation. But the salient one that hasn't been front and center for many years is inflation. We're looking at 5, 6, 7% inflation this year, impacting on individuals in terms of where they're deciding about staying or moving. We're also looking at a situation where non-NHS employment opportunities in service industries are there, and in many cases are seeing significant increases in pay. So we've got to be aware that for staff with transferable skills in local labour markets, it's probably going to become more challenging in terms of retention and recruitment. And I think that means that pay is more front and centre than it has been for some time. And yes, it's done nationally, but there is a need to be aware that within local labour markets, I think the pay dynamic is going to change and it's going to become more challenging.
Tim, it's been estimated that by 2030-31, up to almost 500,000 extra healthcare staff are going to be needed to meet the pressures of demand and to try and recover from the pandemic. That's the equivalent of a 40% increase in the workplace. I'm just wondering whether you feel that's achievable and what you see as the big foreseeable risks to NHS staffing in the coming years. And that's fairly major question to end our first panel on, but over to you, Tim.
It's a huge, I have a simple correct answer to that. It's a huge challenge, clearly. It's one of the many reasons why a comprehensive national workforce plan is needed, and that's obviously something that effectively NHS has recognised this week. I think at all points in the process, you need to think nationally, but also regionally and locally, about levers that you can pull now and levers you can pull that only deliver later. And obviously those are very important in terms of training up extra cohorts of people and the balance of investment between them. Do I put a pound into a lever I can pull now or later? And the final point I would make, I think, is when you get to short-term measures and the kind of measures that people out there in the system, many of you are going to be faced with. One often rational within an organisation, but is irrational across the system, is the kind of unhealthy competition between bits of the NHS family that can occur for limited resources. It's the most rational thing in the world to try and make your own offer attractive. If all you're doing is stealing the nurses or the GPs from another place a few miles away, that actually just creates friction and waste in the system.
Tim, I'm glad.
I gather you're a fluent Russian speaker.
Yes.
See, I do read all my notes. Thank you very much. We've come to the end of our first panel. Thank you so much to our first panelists for kicking off a great conversation, making so many interesting and valid points there. We'll take a break now, time to digest all of what's been covered so far. If you have chance, do engage with the speed networking functionality. Perhaps use what you've learnt in that interesting panel as an icebreaker. Just looking at the